सुनिए श्री भगवान कीजिए जन जन का कल्याण कीजिए जन जन का कल्याण प्रार्थना सुनिए श्री भगवान प्रार्थना सुनिए श्री भगवान। धरती पर फिर गूंजे गीता, धरती पर फिर गूंजे गीता, भूमि भाग बन जागे सीता, धरती को फिर धन्य कीजिए, धरती को फिर धन्य कीजिए, श्रीधर कृपा निधान प्रार्थना सुनिए श्री भगवान प्रार्थना सुनिए श्री भगवान कीजिए जन जन का कल्याण प्रार्थना सुनिए श्री भगवान प्रार्थना सुनिए श्री भगवान।
Namaste, my dear brothers and sisters. The love and blessings of the Mother and Sri Aurobindo to all of you from Sri Aurobindo Ashram, Delhi branch. This devotional song in the melodious voice of Arunima was accompanied on the guitar by her brother Aditya, is for universal well-being, for everyone to be happy and well. Something that reminded me of that mantra, Sarve bhavantu sukhinah, sarve santu niramaya, sarve bhadrani pashyantu, ma kaschit dukha bhag bhavet. In which we again pray for everyone to be happy and comfortable, free of illness, and not to have the least bit of sorrow. And then in the third line, we have something which seems to be a little out of tune, and that is be tuned to the divine. Now, in fact, that is not really out of tune or not in alignment with the other three lines. The other three would automatically follow as a byproduct if we are aligned with the divine. With that little introduction, let's move on to today's topic, which is diabetes. Diabetes can be of many types, but what we'll focus on is what is sometimes called type 2 diabetes or maturity onset diabetes or non-insulin dependent diabetes. In fact, the currently favored term is type 2 diabetes because although it was called maturity onset diabetes, it no longer seems to be confined to the mature age. It can happen at much earlier age, and in fact, the trend is towards people in their 30s and 40s often getting diabetes. And also the term non-insulin dependent diabetes is a misnomer because many of those who have type 2 diabetes may need insulin even after they have been on oral hypoglycemics for quite some time. Eventually, they might need insulin alone or in addition to the oral hypoglycemics. So it's not strictly speaking completely non-insulin dependent diabetes mellitus. The prevalence of diabetes is going up at an exponential rate, and in India, it's a major concern now as a major public health problem. And therefore, I'm sure many would be interested in knowing a little more about it. So, and of course, it's a lifestyle disease like the other diseases that we have been talking about in this course. But there is one difference. In case of diabetes, for the patient to understand the disease is much more important than in case of other lifestyle disorders. In other lifestyle disorders, the person can just start improving the lifestyle, and uh, if one wants to go to the root, or just follow advice in terms of the medication required. But in diabetes, even if the person is on medication and does not care much for the lifestyle, still understanding the disease is of vital importance. So patient education is in fact a part of not just prevention, but also management of the disease. Let me start with this quote from Shakespeare. Sweet are the uses of adversity. And that, in fact, is something that we have been talking about repeatedly in this course, that anything, even if it appears to be adversity or misfortune, carries in it the seeds of something that is sweet, and that is spiritual growth. Now, this is a recap, sort of a picture of the gastrointestinal tract. And after the stomach, we have the C-shaped structure, the duodenum, and nestled in the C is the pancreas, where insulin is made, the deficiency of which gives rise to diabetes. And the pancreas is a two-in-one organ, as seen in this microscopic picture of the pancreas. It has digestive glands, and the product of these digestive glands is conveyed through this duct to the small intestine or the duodenum, where the juices, the digestive juices, participate in digesting carbohydrates, proteins, and fats. In fact, it's one of the most potent digestive juices, which has enzymes for digesting all the nutrients. But then about 1% of the pancreas is occupied by another type of cells which do not send their products through this duct into the small intestine. They secrete it directly into the blood. And anything which is secreted directly into the blood is called a hormone. And these hormones are manufactured by these cells, which are like these small little islands uh, here and there scattered throughout the pancreas, uh, between these digestive glands. So these are the islets. And within these islets, there are many types of cells. It is the B cells in the islets that manufacture insulin. Here is a more realistic picture, the C-shaped curve of the duodenum and the pancreas nestled there. The endocrine part occupies, that is, the islets occupy only about 1% of it, but this 1% has about 1 million such islets. Another picture showing these digestive glands and the endocrine cells, amongst which the B type of cells manufacture insulin. The islets were discovered by Langerhans when he was just 21. And insulin was discovered by a surgeon, Frederick Grant Banting, when he was in his 30s, and Charles Herbert West when he was still a medical student in his 20s, and this discovery happened in 1921. So, in a way, both these major discoveries related to diabetes, that is, the discovery of the islets of Langerhans and the discovery of insulin, were a gift of the youth to the world. Both these, all these three investigators involved were young. And this was one of those discoveries which found very quick application. Uh, the idea was conceived by Banting, the surgeon, uh, in a flash of inspiration in 1920. Insulin had been discovered by 1921. And in 1922, the first patient, a 14-year-old boy having diabetes, actually received insulin and was saved. And the discovery was honored with a Nobel Prize in 1923. Now, what does insulin really do? Food has two basic functions: to serve as fuel and to build the body for growth and repair. Insulin helps both. Uh, as a result of what we eat, the after digestion, quite a bit of this food yields glucose, and this glucose enters the blood, and insulin helps in utilizing this glucose. What can glucose be utilized for? It can be utilized as fuel. It is the preferred fuel of the body. Insulin helps in utilizing this glucose as fuel. But then uh, at that stage, soon after eating, when a lot of glucose has entered the blood, it is surplus. It is more than our immediate needs, and therefore it should also be stored. Insulin helps us in storing it as glycogen, and it also helps us in storing it in the form of fat by converting some of this uh, glucose into fat. And insulin also helps in the process of growth and repair by helping the synthesis of proteins. So, in other words, insulin helps us make the best use of food, utilize the fuel in a proper manner, use the preferred fuel glucose, and use the reserve for storage, growth, and repair. But the focus today will be on insulin helping in utilizing glucose. Now, deficiency of insulin may not be absolute. That is, there may not be an actual reduction in the capacity of the pancreas to manufacture insulin. It may be only a relative deficiency, which means the meal is such that it requires more insulin than the pancreas is capable of. The same pancreas, which may be a little aged, which may be a little tired, may be able to cope with the glucose load if the meal is such that it does not release too much of glucose all of a sudden. And the deficiency may be effective in the sense that the person may be resistant to the action of insulin. There may be plenty of insulin that the pancreas is capable of secreting, but there is insulin resistance. And the most common thing that creates insulin resistance, which can be reversed to some extent, is overweight. Then diabetes is of two types. Type 1, which is inherited, is maybe autoimmune in nature or maybe caused by a virus. All these possible things, possible causative factors could be there. And it's an absolute deficiency and therefore has to be treated with insulin. But type 2 or maturity onset, which occurs later in life, which is due to only a genetic tendency to have diabetes, it doesn't have a straight genetic relationship as in case of type 1. Also, sometimes called non-insulin dependent diabetes, although it's not strictly speaking so. Insulin may be required in the treatment, and again may not occur at a very old and mature age. It's now quite common in 30s and 40s, and therefore the favored term these days is type 2. Here, the deficiency of insulin, either relative or effective, it is not absolute. Now, what are the symptoms of diabetes? A person with diabetes has deficiency of insulin, be it absolute, relative, or effective, but there is a deficiency of insulin. And therefore, the person cannot utilize all the glucose that has entered the body. And if it does not enter, if it is not able to utilize it, the person feels hungry because the hunger mechanisms respond not to the availability of glucose, but to the utilization of glucose. Since glucose is not being utilized, the body interprets this as if glucose is not available. And therefore, the person feels hungry. The person tends to eat more, which is polyphagia. Now, the glucose that is flooding the blood gets filtered in the urine and may appear in the urine. So, the person may have glucosuria, that is, glucose in the urine. Now, in order to be able to pass this excess glucose in the urine, the person has to pass more water also to dissolve that glucose. So, the person passes excess urine, which is polyuria. And because the person is losing more water in the urine, the person feels more thirsty. So polydipsia. So the three P's, classical P's, polyphagia, polyuria, and polydipsia. And although the person is eating more, but the food is not being utilized properly, the person loses weight. To start with, a person who gets diabetes is generally overweight. But as diabetes proceeds, the person in fact may lose weight, but that is not the right way to lose weight. Uh, but all the same, the person may lose weight. And because the person is not able to utilize food, is hungry, and is losing weight, in spite of eating more, uh, the blood is flooded with glucose all around, but not a molecule to eat. So it's been also called starvation in the midst of plenty. However, all these symptoms which we talked about, the classical symptoms may not be there. And diabetes may be first detected because of repeated infections that can happen in diabetes, or an ulcer somewhere that refuses to heal, somewhere on the skin, or a persistent itch or a skin rash, or one of the complications of diabetes, which we shall come to later, like retinopathy, nephropathy, or neuropathy. So it may be one of the complications that may lead to the detection of diabetes. Or there may be no symptom at all, not even the complications. And therefore, only half of those who have diabetes actually know that they have it. And that is the significance of going in for a regular checkup. And one of the, uh, two of the common tests which are done are blood glucose and urinary glucose. Now, what is the relationship between the two? Glucose appears in the urine only when the blood glucose exceeds 180 milligrams per deciliter, because that is the renal threshold. Whatever glucose is there in the blood gets filtered, but then it is reabsorbed. It is taken back into the blood. It does not appear in the urine. But reabsorption has a limit. Taking the glucose back from the filtrate into the blood has limits. That happens only till the blood glucose level has reached 180 milligrams percent. And if it crosses that, then whatever is in excess goes in the urine. And therefore, when the blood glucose level is higher than 180, uh, glucose appears in the urine, which means that suppose a person goes for a fasting blood sample and overnight the person has not eaten, the person has borderline diabetes, and therefore the glucose level has fallen below 180. The person is not passing any glucose in the urine. We take an early morning sample that has no glucose, but that doesn't mean that the person does not have diabetes. If we do a blood glucose, even if it's a fasting blood glucose, it may come to 140, 150, 160, or something like that, which is not enough to give us glucose in the urine. But for fasting level, that 150 milligrams percent is high. It indicates an early diabetes, uh, and therefore, uh, blood glucose is what may actually detect the diabetes. Which means, in other words, that if glucose is present in the urine, then yes, the person most probably does have diabetes. But if it does not have glucose in the urine, that does not mean that the person does not have diabetes. Now, when it comes to blood glucose, we sometimes have these four types of investigations. The first is random. Just take the blood sample when the patient happens to be available. When the person is available, take a sample anytime. So that is random. blood glucose. The other is fasting, that is, the person comes after an overnight fast. And the other one is postprandial. In addition to fasting, then after the person's fasting blood sample has been taken, the person takes a meal and we take a sample 2 hours after the meal. That is postprandial. Because during these 2 hours, what the person has eaten gets absorbed into the blood glucose goes up, and we can see to what extent the person has been able to cope with this challenge of a higher blood glucose. How has it gone? How has it gone? How high has it gone after the absorption of that glucose from the meal? But then the same thing, that is fasting and postprandial, can be done in a more systematic way, in a calculated way, in an oral glucose tolerance test. And here is how an oral glucose tolerance test is done. Uh, the person's fasting blood glucose sample has been taken. At time 0, the person is given orally a measured amount of glucose, usually 50 grams of glucose, and sometimes 75 grams of glucose. And as a result, the blood glucose level starts going up. This glucose is absorbed and the blood glucose level starts going up. We sample the blood at half an hour, 1 hour, 1.5 hours, 2 hours, and sometimes for research purposes, even a little beyond 2 hours. And we find that in a healthy person, the curve is something like this. Even the peak remains below 180, and therefore there's no glucose in the urine. So this is half an hour postprandial. So this is what is called the glucose tolerance test. It shows how well the person can tolerate a large amount of glucose suddenly entering the blood. So how well the person can tolerate it, cope with it. So in that sense, it is glucose tolerance test. It's oral because the glucose has been given orally. In addition to these, sometimes on the blood we also do, in fact, routinely we do now, is glycosylated or glycated hemoglobin, abbreviated as HbA1c. The significance of this is that glucose has a tendency to bind to hemoglobin. Hemoglobin is there in the red blood cells. So a small fraction of the hemoglobin in the red blood cells gets converted into glycosylated hemoglobin. That is, this hemoglobin is attached to glucose. And since the lifespan of a red blood cell is 3 months, it would stay there for 3 months in these red blood cells. And then, of course, when the red cell is destroyed, the hemoglobin and glucose and all will split. In other words, if we take, say, a sample of blood and measure in that the glycosylated hemoglobin, then it will give us an idea of how well, or rather, it will give us an idea of how much glucose has been present in the blood on the whole, a sort of an integrated average over a period of about 3 months, particularly over the last 1 month. So it gives us sort of an overall picture of how high the blood glucose has been on the whole during the last 3 months, particularly during the last 1 month, irrespective of fasting, postprandial, and all that put together. So what is the integrated average over the last 3 months? And this has a value because that is closely related to the complications of diabetes. And for preventing the complications, the most important thing is good glycemic control, that good overall control of the blood glucose level. Of course, if we prevent diabetes, there can no question of complications. That is the best. But if the person does have diabetes, then good glycemic control is the most important thing for preventing complications. And we get a good idea of the glycemic control from the HbA1c levels. And now there are converters available. That is, through mathematical calculation, from HbA1c, we can get an estimate of the average glucose level during the last 1 to 3 months. So that is the estimated average glucose. So this is a sort of a blood test with a memory that goes up to 3 months, how well the blood glucose has been regulated during the last 3 months. Good control, less than 7. One has to be careful if it is more than 7 but less than 8. And if it is 8 and above, then it indicates poor control. Again, how good the glycemic sort of control has been over the last 3 months. here it's shown that you can, that this is excellent, this is good, this is poor. That is uh, HbA1c 4%, 5%, 6% is excellent, 7 to 8 good, and 9 and above poor. Uh, Converting it into blood glucose levels, as I said, now we can convert. We have mathematical relationship uh, has been worked out. So this corresponds to a mean blood glucose level of 50, 80, 115, and so on. So you can see that the blood glucose level is higher, and excellent is if the uh, average over the last few months has been less than 115 or so. These are relatively simple charts that I've shown, and but there are much more complex charts also available, more detailed. What are the complications of diabetes? The three classical ones are the three pathies: retinopathy, nephropathy, and neuropathy. Now, if retinopathy is detected early, the progress can be halted. And that's why it's important for a person who has diabetes to get an annual checkup of the eyes. And what the doctor finds is that, in contrast with a normal eye, which has these normal blood vessels, what has happened in case of diabetic retinopathy is that the small blood vessels in the retina, which can be seen in the fundus examination, uh, through these, some blood and fluid has oozed out. So damage is in the blood vessels, and some fluid and blood has oozed out, and is leakage of these blood vessels is what tells the doctor that this patient has retinopathy. Retinopathy is serious because retina is where the image is formed, where we have the receptors for vision. When the light enters the eye from an object, the image is formed here. And this is sort of an extension of the brain, one can say, the nerve cells here. And once, if this is damaged, then the person gets can eventually get blind, and for that, so that's why it's a serious complication. However, one does not have to go to that stage of blindness. If the detection is early, it can be halted through a little more rigorous glycemic control. It's controlling the blood glucose level more rigorously. One can check the progress of diabetic retinopathy. The other important complication is nephropathy, but retinopathy generally starts before nephropathy, the early signs of retinopathy. And that's the stage at which it should be halted. That further increases the importance of an annual uh, eye checkup, in which the fundus should also be checked up, where these blood vessels can be seen. So retinopathy generally occurs before nephropathy, and along with the eye checkup, one can also go in for an annual urine checkup for microalbuminuria. Microalbuminuria is a little confusing term. It does not mean a different type of albumin which has small molecules. That is not the type of albumin we are detecting in the urine. What we are detecting is normal albumin, which is a plasma protein, which is there in the blood anyway. We are detecting it, but the amounts present are small, and that is why microalbuminuria. It's a relatively small amounts. That's only a moderate increase in albuminuria. It's not a heavy increase. It's a small amount of albumin present in the urine. So micro refers to the small amount that has started appearing in the urine. Normally, albumin or any protein does not appear in the urine because when the blood is filtered in the kidney, the proteins do not get filtered. They still stay in the blood because protein molecules are too big to be filtered. And the filter holds the sieve in the kidney, the sieve where the filter is present, has holes which are too small for protein molecules to pass out. Protein molecules are too big to pass through that filter. But if the kidney is damaged, the filter is damaged. And if the filter is damaged, larger molecules can pass out. And among these larger molecules are proteins. And among the proteins is albumin. So an early sign of nephropathy is that small amounts of albumin start passing through the filter. And once they pass through the filter, they appear in the urine. And the third complication is neuropathy. And depending upon which nerves have been involved, one can have various types of symptoms. Uh, it's an early and almost universal complication for which there is no real cure, but all the same, it can warn the person about the diabetes being uncontrolled or poorly controlled. And if present, if neuropathy is present, the signs could be weakness because the muscles are supplied by nerves. If those nerves have been affected, the person would be weak. And if it's the sensory nerves that have been affected, then the person will find it difficult to feel stimuli like touch, pain, or temperature. And the person, if the autonomic nerves are affected, the person may have constipation, diarrhea, poor control of the urinary bladder, or sweating. And because of the slowing down of the reflexes, where again nerves are involved, if the person changes the posture from lying down to standing up, the person may have a tendency to develop low blood pressure and may feel dizzy and may faint. Now, this is because there are reflexes in the body which help us uh, increase the pumping of blood when we change the posture from lying down to standing up. When we stand up, the blood has to be pumped to the brain against gravity. And to be able to do that, the heart should pump more blood and there should be other adjustments in the cardiovascular system. Now, those adjustments take place quickly in time as we are changing the posture from lying down to standing up if these reflexes are in good shape. And for the reflexes to be in good shape, the nerves which are involved in these reflexes, they should be in a good shape. So if in neuropathy these nerves have been affected, these reflexes do not work briskly enough, and the result is that the person may faint while standing up. Another complication of diabetes is the diabetic foot, an ulcer in the foot that refuses to heal. It is the foot that gets injured most commonly when we walk, but we have a warning signal sign away, walk or anytime in a barefoot. Uh, so the foot bears the brunt of whatever is there, which can hurt us on the road, and whether it's the foot or elsewhere. But because the person has peripheral neuropathy, the person does not feel the pain. So that protective mechanism is not there. The protective pain is not there, and therefore the injury may be there. The person doesn't know it. The person doesn't care for it because it doesn't pain, and the result is there's an ulcer. And then because of diabetes, ulcers in general heal very poorly because there's plenty of sugar available. So germs start infecting the wound, and that prevents healing. And the germs get plenty of food because of the high blood glucose. And the result is that these ulcers refuse to heal and can become really serious. So here in this picture, those complications of diabetes have been summed up. Retinopathy, uh, nephropathy, uh, neuropathy, diabetic foot, and of course, this person also becomes more vulnerable to heart attacks, cardiovascular, coronary artery disease, and to cerebrovascular disease, that is stroke, because this is a cluster of lifestyle diseases that tend to go together. Now, the treatment of diabetes is essentially a balancing act, balancing the factors which increase blood glucose and factors which reduce or lower blood glucose. Factors which raise the blood glucose are food. Food releases after digestion glucose, which enters the blood, so it raises blood glucose. But apart from food, indirectly, other things can also contribute to raising the blood glucose level. Uh, Sedentary life means less utilization of glucose, mental stress, which releases hormones which have actions essentially opposite those of insulin. So, insulin lowers blood glucose, these hormones raise the blood glucose. Now, these are other factors which could raise the blood glucose level. Factors which lower the blood glucose level are fasting. If one doesn't eat, naturally blood glucose level will come down. Insulin, which uses up the glucose and therefore the blood brings down blood glucose. Mental relaxation, just the opposite of stress. Uh, it helps in lowering blood glucose. And any physical activity also helps in lowering the blood glucose because physical activity needs fuel in the form of glucose. So, treatment of diabetes is balancing the factors which raise blood glucose and those which lower it so that the blood glucose level is maintained at the normal level. And therefore, pay attention to diet, pay attention to mental stress. The person becomes more physically active, and the person may need insulin or something which acts like insulin, that is, oral hypoglycemic agents or the pills for lowering blood glucose. Classically, we look at the treatment of diabetes in terms of three factors: diet, exercise, and medication. In the early cases, that is, in milder cases, only diet and exercise may be enough. But in many cases, medication may also be necessary. So, this is the tripod, which is the core sort of the treatment of diabetes. Now, first, let's talk about the diet. And talking about diet is risky because there are many liberties which most diabetics do not know that they can take. But then once you tell them that you can take these liberties, for example, you can eat sugar, you can eat rice, you can eat bananas, you can eat grapes, and that they understand. But along with that, the other complexities that go, which will allow all this, that they don't understand or they refuse to understand. So they take one part but not the other. And therefore, talking about diet can be risky. And there's something like integral yoga, where you tell them that in integral yoga, renunciation of life is not important. You don't have to renounce the world. You don't have to go to the Himalayas. You can practice integral yoga while living in the real world, going about your normal duties and responsibilities at home and at the workplace. That they understand. But then how you have to uh, change the way or the attitude with which you live this worldly life, that they don't understand. It's very easy to pick up in the easier part and ignore the difficult part. So that's why talking about diet can be risky. And if you find that the complication or complexity you're not willing to digest, then it's better to just go by the conventional advice of a chart of things that you should not eat if you have diabetes. Now we'll go to the basis of how a diabetic diet can be designed. That is, what is the scientific basis for designing a diabetic diet? And for that, the base remains this oral glucose tolerance test, which we talked about. That is, you give, say, 50 grams of glucose at this point, and then measure the blood glucose every half an hour. And the curve is something like this. And AUC stands for the area under the curve. And this, uh, area with these slanting lines, that is the area under the curve, which gives an overall picture of the glucose tolerance. Now, this curve depends upon what has been eaten. We saw the curve after giving 50 grams of glucose. But if instead of 50 grams of glucose, we give a measure 50 grams of sugar or white rice, which contains 50 grams of carbohydrate in the form of starch, or brown rice, which also contains 50 grams of carbohydrate in the form of starch, then the curves are somewhat like this, which means that the sugar raises the blood glucose the most, white rice the next, and the brown rice the least. Which means that the extent to which the blood glucose goes up depends upon what has been eaten. And in case of rice, it rises not as much as in case of sugar because rice contains carbohydrate in the form of starch. Starch has to be digested. The digestion takes time, and therefore the glucose is released slowly. Brown rice, in addition to having starch, also has fiber, and this further delays the absorption of glucose, slows down the absorption of glucose, scatters it over a longer period of time, and that's why the peak reached is less, and the peak is reached not at half an hour, but a little later. Apart from fiber, the protein and a little bit of fat that is present in rice also helps in slowing down this rise. So pure sugar or glucose raises it much more. The company of protein, fat, and fiber slows down. So more of these other nutrients present along with the carbohydrate, the better. And if the carbohydrate is in the form of starch, which is called complex carbohydrate, that is better than a simple carbohydrate like sugar or glucose. So all carbohydrates are not alike. They all give 4 calories per gram. In that sense, they are the same. So whether it's starch or glucose, the energy content is the same, 4 calories per gram. But how they behave in the body in terms of the rise in blood glucose is different. Refined cereals like white rice or white bread, maida, they give a higher peak. So like white rice, white bread or maida will give a higher peak than brown bread or whole wheat, say dalia, porridge made from whole dalia or cream of wheat, suji. Now these will give a lower peak. So refined versus unrefined, and this applies to cereals as well as pulses, legumes, dals. They also can be refined or unrefined. So if the seed coat is intact, they'll give a lower peak. And the rice will be spread out over a longer period of time, as in case of this brown rice. Now, people have commonly asked about many food items. One of them is rice. If I have diabetes, should I stop taking rice? This is probably also common advice, and that is what perpetuates this idea. But the problem is not with rice itself. The problem is rice is twofold, and that's why it's generally discouraged. What people generally eat is white rice, not brown rice. White rice is more palatable and less expensive. And also, generally, the quantity of rice consumed is huge. It's a whole big pile of rice on the plate. Whereas when a person takes bread or chapati, then it may be just 2 chapatis or 2 slices of bread. Now, that does not have the same amount of energy, the same amount of starch. Its energy content, the caloric content is not the same as that of the big pile of rice. So the quantity consumed is generally too much, and therefore the blood glucose rise depends not only on what has been eaten, but how much has been eaten. That's why in the standard test, we standardize the quantity also. It should provide only 50 grams of carbohydrate. So the quantity also matters. So generally the problem with rice is that people generally consume white rice, not brown rice, and they consume too much of this rice. If these two factors are taken care of, a person having diabetes can also have rice. Now, once again, we come to glucose tolerance test for a reason, because this is how the glycemic index of a food is calculated. For that also, the basis remains the same, the glucose tolerance test type of tests. If the reference food is glucose, and that is what currently is the reference food, if we give 50 grams of glucose, and we get a curve like this. Now we want to calculate the glycemic index of a particular food. Suppose for food 1, we give just in the same way the food, food 1, of which we want to know the glycemic index, in such a quantity that it will have 50 grams of carbohydrate. Instead of glucose, now we are giving 50 grams of carbohydrate in whatever form the food has it at this point, and the curve may be something like this. And we have another food, food 2, which gives a curve like this. Now, you can see obviously that this is a much better curve from the point of view of diabetes, because it is not challenging the body uh, as much as this food in dealing with the glucose. So insulin available may be able to deal with this peak all right, but may not be able to deal with this peak. So that's the significance of glycemic index. Now, what is the glycemic index? The glycemic index is the area under the curve for the food. So this area of slanting lines. So if we want to know the glycemic index of food 1, we'll take this area, divide it by the area under the curve for the reference food, divide it by this area. Now this is bigger than this, and therefore if you multiply this by 100, the glycemic index will be less than 100. Say if this area is 80% of this, the glycemic index will be 80. If this is 40% of this food too, this area is 40% of this, then the glycemic index will be 40. Now, foods which have a glycemic index of more than 70 are generally considered high glycemic index foods. Those which have 55 to 69 are medium glycemic index foods, and less than 55 is low GI. Now, which are the healthier foods? Foods with a low GI or those with a high GI, and why? Foods with a low GI are healthier because, firstly, they do not challenge the capacity of the body to deal with glucose to such an extent as those which have high GI. Because the person may have a reduced capacity to manufacture insulin. The person who is going towards diabetes may have a reduced capacity to deal with glucose because less insulin can be secreted in response to a glucose load. But if the load is lower, the peak is lower and scattered over a longer period of time, as happens in case of foods with a low GI, the person may be able to cope with it. The person will not show any signs and symptoms of diabetes in borderline cases. And if the person actually has diabetes, foods with a low GI will help him manage with less medication. They'll be kinder to the pancreas. They'll be easier on the pancreas to deal with. The second important thing is that foods which have a low GI also have a long-term effect. Their long-term effect is to improve glucose tolerance, which means that they increase the sensitivity of the body to insulin. The a person becomes more sensitive to the effects of whatever insulin is available, which means insulin resistance goes down. The person has a greater sensitivity to insulin and therefore a better glucose tolerance. So there's a genuine improvement in the capacity of the person to cope with the challenge. So these foods provide less challenge and also improve the capacity of the person to meet the challenge. So foods with GI are healthier because they are less of a challenge to the mechanisms for coping with the glucose rush after a meal. Secondly, low GI foods also have a long-term impact. They improve glucose tolerance, which means they improve the capacity to meet the challenge. Now, this is a general sort of guide to the glycemic index. Whole grains which have the seed coat intact, that is the fiber in these whole grains, helps. So they have a lower glycemic index than refined grains. Fermented foods like idli and dosa, their glycemic index is lower than that of unfermented foods. That is the corresponding amount of rice and dal, whatever has gone into the idli, dosa, etc. The glycemic index is further brought down beyond what is uh, possible with those foods just because of fermentation. Then unripe bananas have a lower glycemic index than ripe bananas. And refrigerated food, interestingly, has a lower glycemic index than fresh food because part of this starch in the food changes into what is called resistant starch while the food is stored in the refrigerator. Resistant starch does not get digested. It behaves like dietary fiber. And since from the same amount of food now less starch is available for getting digested and absorbed, the glycemic index goes down. Now here are a few foods, the glycemic index of which has been shown, and you can see that the difference can sometimes be only marginal. Say if you compare brown rice with white rice, the difference in the glycemic index is not enormous, 68 and 73. This will fall in the high glycemic index, this in the medium glycemic index foods. But some cereals like buckwheat, kuttu, which is eaten during the fasting season, has a much lower glycemic index. Barley has a very low glycemic index. So some of these millets which are not commonly eaten have a much lower glycemic index than wheat and rice. Wheat, you can see, wheat is high, rice is high. These millets have a lower glycemic index. And French fries, the fat will bring down the glycemic index of the potato. Potato is 78, French fries is 63. So fat brings down this glycemic index. But then fat also adds to the calories. So that one has to keep in mind because French fries, one will put on weight, although the glycemic index is lower, unless one reduces the quantity. You can't take the same amount of potato in French fries and say that the glycemic index is lower. But then, along with the glycemic index goes down, the fat has also increased the caloric content, which will lead to a tendency to put on weight. Ice cream only 51. Again, the same thing. Glycemic index is low because of the large amount of protein and fat in it. In spite of the sugar, the glycemic index is 51. Ice cream has plenty of sugar, but the glycemic index is low because of the protein and the fat present. But then everything put together, the sugar plus the fat plus the protein, everything is contributing to the high caloric content of ice cream. So that has to be taken care of, which means it has to be compensated by taking less of other food so that the overall energy intake does not exceed our requirements. Now, this is a chart which is worth many looks at. A fruit like guava, which the a person having diabetes is told to have freely, has a glycemic index of 80. It is not very low. Whereas grapes, mangoes, and chiku, which are the prohibited fruits on the prohibited list for many diabetics for various reasons, uh, the grapes, these have a glycemic index of only about 50. And that's why you can consume these fruits, just keeping in mind that in the overall intake during the day, energy content does not go up. And of course, a person has diabetes has to be also careful about the timing of the food in relation to the medication. So, some of the general factors which affect the glycemic index is lowered by, which is what we are interested in. We are interested in a lower glycemic index, the company that the food has, which means that the food has, along with the carbohydrate, also some protein, fat, and fiber, and maybe some micronutrients which help in bringing down the blood glucose. Uh, very small amounts of those chemicals which can lower. And this is important because some plant products like bael and neem and karela and so on, and they do it because of minute amounts of some chemicals present which can bring down the blood glucose. So the glycemic index is lowered by the company that the food has through thorough chewing. Now, thorough chewing also increases the time spent on eating and therefore brings down the glycemic index. Then mental peace, a person at rest, at mental peace, has does not produce those hormones which increase blood glucose. And refrigeration. Of course, this is not the best way to bring down the glycemic index of a food, but one should know it. But then what matters is not the glycemic index of the single food, but of the meal, which has a variety of foods. And therefore, we should be interested in looking at the glycemic index of the meal. So if, say, a cup of tea or milk, to which has been added a spoon of sugar, one should not keep thinking of the glycemic index of sugar, which is extremely high. The glycemic index of sugar is around 100. That's true. But then you have added it in milk or tea, which has some protein and fat. And then along with that, you're having some food or a snack, which also has carbohydrate, protein, fat, and fiber. So it is all this put together which counts. And the contribution made by 1 or 2 spoons of tea in the milk or sugar may be negligible. So if you are able to digest this complexity, you can have sugar, but then don't take a lump of sugar. And also, less the better. That is also true for everybody, whether a person has diabetes or does not have diabetes. Less sugar, the better. If you don't care for the taste, you don't care for that sensory pleasure which comes from the taste, don't take sugar. By sugar is not necessary. We don't need sugar. But what I'm trying to say is that if you do like sugar, giving up sugar creates stress. Do not give it up just because you think that by giving it up, I solved the problem of diabetes. I need not to do anything else. You need to do a lot more apart from taking care of the sugar, and a little sugar added as in added at a meal to milk or tea, or a piece of sweet that is eaten with the rest of the meal, so that in the sweet also the sugar is in company of carbohydrate, protein, and fat. After all, the sweet or the dessert does not have just sugar. So If that has been taken care of, the other items in the meal have been taken care of. Like if the glycemic index of the meal as a whole is taken, the contribution made by a few spoons of sugar will be virtually negligible. So that is what really matters. And not only that matters, what matters even more is the total energy intake. And this sometimes is expressed in the form of the glycemic load. Glycemic load of a meal is equal to the glycemic index of the individual foods multiplied by the amount of carbohydrate. So if you find the glycemic load of all the foods present in the meal, then you can see what is the overall impact on of the glycemic index of a single thing like sugar. It will be negligible. It's a very common statement. I have been diagnosed with diabetes, and since I have diabetes, now I stopped taking sugar. Now, firstly, what the person has done was not absolutely essential. Secondly, what the person has done is not sufficient. Just by stopping taking sugar, you cannot solve the problem of diabetes. There's a lot more that needs to be done. But that is neither sufficient nor was it necessary. And then the question arises, if I have diabetes, can I have sugar? Yes, you may, if sugar is in good company. Company of carbohydrate, protein, fat, fiber, and other foods which may have a lower glycemic index. Other important considerations would be the total glucose load of the meal, the energy content of the meal, and hence likely impact on body weight. However, if in doubt, or you do not care for sugar, or you do not want to digest these complexities, it is better to stop taking sugar. Even for someone not having diabetes, less the sugar, the better. Now, apart from this, other considerations in the diet in diabetes are energy, that is the total energy person does not put on weight. Then the fat, as in case of healthy persons, a judiciously chosen fat in moderate quantity. And the best of the fats are soybean oil and mustard oil. But some saturated fat is also not only permissible but also essential in the form of butter or ghee. Proteins, a mixture of cereals and pulses, is good for a healthy person, good also for a person having diabetes. But then cereals and pulses should be taken unrefined as far as possible. Then micronutrients, including antioxidants present in various plant foods, and a concentrated supply is present in spices. These are important also for a person having diabetes. Alcohol carries special risks for a person with diabetes, a person who's on medication, because medication can interact with glucose to lead to a fall in the blood glucose level or hypoglycemia, which can be a risky or dangerous situation, and that we shall talk about a little later. Then the size and the frequency of the meals. If the person is on medication, then this becomes even more important because this has to be synchronized or sort of matched with the timing of the medication, because the medication will help utilize the food and therefore the two have to correspond to each other. But in general, a person who has a tendency towards diabetes may benefit from relatively smaller meals because they'll impose less of a glucose load. And if the meals are smaller and still the person has to eat enough, the person might have to eat more frequently. So small frequent meals is in general sort of a trend that a person with diabetes will benefit from. Apart from diet, in the tripod, we saw there are two other items, exercise and medication. Exercise has an impact on blood glucose as well as on body weight. It brings down the blood glucose level because during the exercise, glucose is utilized. And for utilizing glucose during exercise by the muscles, utilization of glucose by the muscles during exercise does not need insulin. It is independent of the supply of insulin, and therefore it's very helpful. And apart from that, it also helps in regulating body weight. And an overweight person can just lose a few kilos and the blood glucose is likely to come back to normal or at least come down towards normal. Then medication, insulin and oral hypoglycemic agents, they both have their place, and we'll not go into the details. That's for the doctors to decide, the doctor who is treating you, what to give, at what stage, and how much of it. Insulin, of course, has to be taken by injection, cannot be taken orally because it's a protein, and like other proteins, it will get digested in the gastrointestinal tract, and therefore it has to be given by injection. And most people find it quite convenient to learn injecting it themselves. Uh, and they get used to the pain also, so they take the injections of insulin themselves. Now, what is hypoglycemia? Hypoglycemia is low blood sugar, and that can happen to a person who is having diabetes because of a mismatch between the treatment and the factors which raise or lower blood glucose. For example, if a person uh, misses a meal but does not miss the medication, then the medication will still work, bring down the blood glucose, but there is no glucose load that has been imposed in the form of food, and therefore the blood glucose can fall to a low level. Or the person is taken only the usual amount of food, the usual dose, but then the person goes in for some unaccustomed heavy exercise. Exercise uses up the blood glucose, and the blood glucose level may come down. And this can be a dangerous situation because the brain can utilize only glucose, and therefore and this person can faint. So we'll go into hypoglycemia, a discussion on hypoglycemia in some detail. The various situations in which a person having diabetes may develop hypoglycemia are: firstly, if the meal has been missed, the medication has not been missed, but the meal has been missed, or the meal has been delayed. The medication was taken at the normal time, but the meal has been delayed, or the meal has been taken, but the meal was much smaller than usual. Now, all these things would mean that the medication will keep doing its job as normally, but the corresponding meal, which it was meant for to utilize the glucose load properly, that glucose load did not come or came too late, too little. Then exercise, which uses up the blood glucose without even needing insulin, if it was severe or at a wrong time. That is, it was close to the time when the medication was also working. So medication was bringing down the blood glucose, exercise was bringing down the blood glucose, the corresponding food was not there, and that's what can bring down the blood glucose. Or overdose of medication. By mistake, more has been taken than was necessary, and that will bring down the blood glucose. Alcohol interacts with oral hypoglycemic agents, and that can bring down the blood glucose. In intensification of treatment, the person gets very enthusiastic. I will treat my diabetes in the best possible way. The person starts taking intense exercise, and the person also uh, goes in for a strict dietary control, and intensification of treatment itself can lead to hypoglycemia. Doesn't mean that one should not treat oneself properly, but then one should understand the process. If you're doing certain things which are likely to lower the blood glucose, then correspondingly, depending upon your body weight, either eat more or reduce the medication. Now, what are the symptoms of hypoglycemia? The early symptoms are that the person may have palpitation, that is, pounding heart. The person may start sweating. The person may have hunger, anxiety, or irritation. So some of these behavioral problems like anxiety and irritation, because the brain is not getting enough uh, of glucose. The brain can utilize only glucose, and therefore, if glucose levels are low, the brain is affected. And that's how the early symptoms can be anxiety and irritation. And among the late symptoms, confused behavior, slurred speech, muscle incoordination, fainting, death, and eventually death. Now, all these uh, are because of the progressively failing function of the brain. Now, how can one prevent hypoglycemia. Most important is to understand the disease. And that's why patient education is extremely important in case of diabetes. And if one who does not have diabetes, if that person also understands this, the person may be able to prevent diabetes or detect diabetes very early. Another important thing in prevention is that if there is any change in the diet or exercise, especially if it is anticipated, if it is known in advance, if you are expecting anyway that you might have to miss a meal because you are traveling, or that you will be taking exercise which you normally do not take, then compensate for it in advance. If you're going to miss a meal, then miss the drug also, medication also. If one is going to take unaccustomed exercise, again, take either more food or reduce the medication or miss a dose of the medication. Then, usually a person having diabetes monitors blood glucose himself few times in a day. And if at bedtime it is less than 110, again, a bedtime snack will be useful because at night the person may not be able to observe the early symptoms of hypoglycemia. And therefore, if the person goes into hypoglycemia while asleep, it is more dangerous. So better to take a bedtime snack. Now, if a person has to go for a fasting blood test, how many doses of medication should he miss? Of course, that morning, the person should not take medication because he is fasting. If he has not taken food, then he should also not take the medicine for which will bring down the blood glucose because then the person is sure to go into hypoglycemia. But in fact, he should miss the dose of medication even on the previous night because some of the oral hypoglycemic agents, some of these pills which bring down blood glucose, have a duration of action of about 24 hours. And with that type of a 12 to with the duration of action being 12 to 24 hours, safest is to miss the dose of medication on the night previous to the test and also on the morning of the test. So better to miss the dose on the previous night and the morning of the test, not just on the morning of the test. Because the dose taken the previous night, the dose of medication taken the previous night could still be acting when the person goes for the fasting test and may bring down the blood glucose, particularly because the person has been fasting overnight and will not naturally eat before the test has been completed. Now, what about the treatment of hypoglycemia? If it has been detected early, very good, then it is very easy. The person can take 4 spoons of sugar or glucose. And if these are not available, some candy, jam, biscuits, bread, rice, just about anything which has carbohydrate will do. And the more easily digestible and absorbed it is, the better. Which means the higher the glycemic index, the better. Huh? White bread will be better than brown bread here for raising the blood glucose. So 4 spoons of glucose or sugar is the best. So a person having diabetes should keep these handy in the purse or somewhere, wherever the person goes. And such a person is also advised to carry a card on which is written that I have diabetes. And if you please give me this sugar or candy or whatever it is, which is in my purse. If the detection is a little late, when the person is already getting signs of mental confusion and so on, then again, these will be useful and possible. But along with that, medical help should also be sought. And if the person has become unconscious, then only medical help should be sought because, firstly, the person will not be able to take anything by mouth. Secondly, if you force the person to take something by mouth, it may be aspirated into the lungs, which will kill the person. And thirdly, if the person is uh, unconscious, then uh, in any case, medical help will be necessary. And therefore, don't try to treat it because blood glucose will be brought up by an intravenous injection of glucose, which most people will find it difficult to give. It's better to get it done from a properly qualified doctor or nurse. So, or this will need an intravenous injection of glucose dissolved in sterile water. Which is more risky, hyperglycemia or hypoglycemia? If the treatment has been inadequate, the person may have hyperglycemia, and extreme degrees of hyperglycemia, high blood sugar, can also lead to unconsciousness. That happens because when the brain is not utilizing glucose, the body is not utilizing glucose, the body starts utilizing fats as fuel in a predominant way, and fat utilized without carbohydrate being utilized can lead to the formation of ketone bodies. That's what we call ketosis. And ketosis can lead to high levels of ketones, can also uh, lead to unconsciousness. So there can be a hyperglycemic coma with ketosis. Uh, Now, out of the two, hypoglycemia, in fact, is more risky because that degree of hyperglycemia, which leads to unconsciousness, will not develop quickly or easily in most people. Uh, and in any case, will require medical attention and more complex attention. Whereas hypoglycemia is something relatively simple. It is in a person who is on treatment. Some mistake has been made because of which there has been an imbalance. The factors which lower blood glucose have dominated those which raise blood glucose, and that's how the person has gone into hypoglycemia, low blood sugar. And there are early warning signs. If the person recognizes those, then the person can treat himself. He may not need any help. The person just has the right thing available in his purse and he takes that. So hypoglycemia is more risky as well as more easy to treat. So low blood sugar is more risky than high blood sugar. And why this is important to know is that if you find a person with diabetes who is having some symptoms of confusion, etc., or relatable to the brain, and you are not sure whether it is because of high blood sugar or low blood sugar, then it is better to give this person 4 spoons of sugar than to try and treat as if the person has hyper. Don't give him insulin. So instead of giving insulin, it is better to give him 4 spoons of sugar because that will not do further much harm. It's insulin. If it is all the person already has hypoglycemia, that insulin can do much more harm. So something which brings down the blood glucose further in hypoglycemia can be fatal. It can lower the blood glucose suddenly and quickly to a level where the person may die. But in hyperglycemia, a few spoons of sugar will not kill the person. So in doubt, better to give sugar than insulin. But one should try and understand the difference. Both can give rise to coma, and hypoglycemia is more risky, easier to treat, and it's better to treat it as hypoglycemia in case of doubt. So living with diabetes is essentially a balancing act, balancing the factors which raise blood glucose in those which lower blood glucose. And this living is easy and possible. A person with diabetes can have as long a lifespan as any healthy person and can be just as active and productive in life as any healthy person. But it is more than a balancing act because the lifestyle as a whole needs attention, not just the tripod. And lifestyle as a whole includes many other factors like, above all, taking care of mental stress. And all these things, the tripod, as well as the other factors, are taken care of by yoga. Yoga includes a change in the diet, it includes physical activity in the form of asanas and pranayamas. It does not include medication, which is good, and it also includes uh, potent, infallible prescriptions for lasting mental peace. But some of the confusion that persists about yoga in relation to diabetes is that the image is of yoga is that of asanas and pranayamas and nothing more. And therefore, people quite often look for specific asanas or pranayamas which will cure diabetes. Such specificity does not exist. And therefore, it's better to look upon diabetes as only a trigger, a wake up call, which has made the person more conscious of a holistic view of the lifestyle as a whole and not insist on just a simplistic solution like tell me a few asanas which will cure diabetes. The claims, another thing which confuses the picture is that many of the those who uh, teach yoga make fantastic claims. They make fantastic claims that yes, your diabetes can be cured. I'll teach you a few asanas like Bhujangasana and Dhanurasana that will cure your diabetes. Now, these are fantastic claims. If they had been valid, they would have been widely known by now. And the approach very often is not only enthusiastic and fantastic, but also fanatic in nature. And also sometimes either or approach. That is, either you can take medication or you can do yoga. So yoga is easier, do yoga, forget about medication. It's not an either or approach. It may require a combination of the two. Uh, Yoga in a comprehensive way, looked at in a comprehensive way, might help in reducing the medication, or in case of early cases, taking away the dependence on medication, but it is not an either or situation. Then the criticism of the approach of modern medicine to diabetes is totally unfounded because it is modern medicine which, in fact, revolutionized the treatment of diabetes. Uh, After the discovery of insulin, the picture of diabetes changed so dramatically, and it was only after that that the person having diabetes could live a full and healthy life. Before that, it was difficult. Of course, diabetes itself was extremely uncommon those days. That is different. But then that again can be traced to the lifestyle as a whole, to mental stress particularly. But then the criticism that the approach of modern medicine to uh, diabetes is not right because it leads to lifelong dependence on medication and so on is completely unfounded. The explanations given for how yoga works in diabetes are also generally incorrect. The usual explanation given is that asanas like Dhanurasana and Bhujangasana, which squeeze the abdomen, release insulin from the pancreas, and that's how it helps. Pancreas is not a bag of insulin that you just squeeze it and release some insulin anytime you like. You need insulin at a particular time when the food has to be processed, firstly. Secondly, you cannot squeeze insulin out like that. There are much finer, more subtle mechanisms in the body which send signals to the pancreas when to secrete the insulin. And if those signals are not working enough and not giving enough insulin because of whatever reason, or that insulin is not effective enough, then it is not squeezing of the abdomen which will help at the wrong time because the person is taking exercise, the person is using up asanas are also exercise. The person is using up glucose during that. The person is fasting. The person is doing those asanas on empty stomach. That is not the time to release insulin. Thank God insulin is not released like that just by squeezing the pancreas by Dhanurasana. Otherwise, the person will go into hypoglycemia while doing the Dhanurasana. That insulin is not released. And in fact, we did a study just to test this extremely common misunderstanding explanation, which yoga teachers just keep repeating generation after generation. The person learns it from his teacher, and without thinking, he repeats it that if you do Dhanurasana, then insulin will be released because you squeeze the pancreas, and that's how your diabetes will be cured. We did an investigation on in which we had a set of asanas which are thought to help diabetes, and another set of control asanas which are not particularly associated with treatment of diabetes. In either case, we found that there's no insulin released, and the benefits that the people got by practicing these, they did get benefits, were not because of release of insulin. The benefits were not different in those who did the reputed asanas like Dhanurasana and Bhujangasana as compared to those who did the other asanas which are not so reputed, which do not have that reputation. And in fact, one thing interesting that emerged was that the sensitivity to insulin went up, which means there was a long-term impact in the form of, apart from, of course, the physical activity helps by utilizing glucose. That is different. But it may also help by helping lose weight. But there was a subtle long-term impact in the form of improving the sensitivity to insulin, which improved the glucose tolerance. So the person became sensitive to the effects of whatever insulin was available in the body. But it's the body which was releasing it at the right time, not at the wrong time by squeezing the pancreas. Now, just a few questions at this stage. How much sugar do we need? We do not need sugar. People lived before it was possible to manufacture sugar quite healthy. So, eating sugar is not a necessity. But that is not the same as saying that we should take no sugar at all. The body also has enough resilience to be able to tolerate a certain amount of sugar. And applies not only to the healthy person, but also to a person having diabetes. The upper limit is said to be about 10% of the energy intake, which is a very liberal allowance, allows at least 8 spoons of sugar in a day. But then these 8 spoons are not essential. And one can take anything between 0 and 8. One can take only 1 spoon a day, 2 spoons a day, 3 spoons a day, because sugar is not a necessity. Less the better. But then an absolute ban is not essential, so long as one keeps in mind that the sugar is in good company, it is part of a mixed meal. And in any case, that it will generally be, because nobody is going to just swallow a lump of sugar. Now, why is starch better than sugar? It's better because starch is a bigger molecule. It is plentiful in our staple foods, takes longer to digest, or is natural while sugar is artificial. The starch is a bigger molecule, but that has nothing to do with its being better from the physiological point of view. It's plentiful in our staple foods, which is good, but then that is not the reason why it is better than sugar. Starch is natural while sugar is artificial. The division between natural and artificial itself is artificial, because whatever man makes is also made by man, who is a product of nature. But anyway, that apart, most important thing is starch takes longer to digest. And therefore, the glucose that is released from starch is released slowly. So 50 grams of carbohydrate in the form of starch releases glucose slowly as compared to just glucose itself or sugar. So it's primarily because it takes longer to digest. So the glucose is released slowly, the peak reached is lower and spread out over a longer period of time. Now, understanding diabetes is extremely important, and this is a general statement which holds particularly true for diabetes. Knowledge, when it goes down to the root of our troubles, has in itself a marvelous healing power, as it were. For a person having diabetes, I'll not say diabetic, because we avoid using the term diabetic, because it looks as if he's a different type of a human being, or he has a label. He's just a human being. Diabetes is only a small part of it. So the person has diabetes, the person is not a diabetic. So anyway, so a person who has diabetes, for him, it is particularly important to go to the root of the disease, because then he can manage it extremely well. Without his own participation, it will be very difficult to manage diabetes properly. This book has quite a bit about diabetes, but much more you will find in these two books, Back to Health Through Yoga, which has a long 30-40 page long chapter on diabetes, 212 to 245, more than 30 pages. And Eating Wisely and Well, in which also quite a bit of it comes in the chapter on carbohydrates. This is an inside view of the meditation hall of Sri Aurobindo Ashram Delhi branch. You're all welcome there. And, you may find an opportunity to come here for the YES.05 course, which has been now, which we are now in planning, and a questionnaire has been circulated to you. Please try to respond to that questionnaire as early as possible. And for any questions or comments, you can always drop an email to yes@yesspirituality.com. The anatomical pictures, like those of the pancreas and the duodenum in this presentation, have been taken from Tortora and Grabowski's Principles of Anatomy and Physiology. And apart from that, the internet is a great source, particularly Google for images and information, and Wikipedia for all the information and some images, which have made it so easy to make these presentations. Gratitude to the Mother and Sri Aurobindo for making these sessions possible. And thank you all for being there and listening patiently through this long session. Any questions?
Yes, there's one question. Can things like jamun or bitter leaves reverse the diabetes?
They might, but then all reversals take in general much longer than those measures which act on the end result. The end result is high blood sugar. You give insulin or oral hypoglycemic, it comes down. Whereas a reversal takes longer. And therefore, that's I said, it's not an either or approach. Uh, Something which acts at the end result buys time. It will reduce complications. In meantime, keep working through the other approaches which may eventually reverse the disease. That would include some foods, some herbs, because there are at least 100 different herbs and plant products now known, which could be beneficial in diabetes, either by bringing down blood glucose or by healing the pancreas itself, which will eventually lead to reversal. Reversal may be complete, reversal may be partial, reversal will in any case take time. So it's not an either or approach. Keep trying the other measures. And then if you find that the blood glucose are now having a tendency to go below normal, then consult the doctor. He may reduce the dose of the medication. That would be the sort of a proper integrated approach to the issue. Among the plant products, those which were recently investigated scientifically, methi was probably the first one investigated by the National Institute of Nutrition at Hyderabad, and they found it was useful. But then by now, there are at least 100 or so plant products which have actually been tested and found to have some beneficial effect in diabetes. But their standardization, etc., and how long they will take to work, particularly when it comes to reversal, that one cannot be very sure about. So therefore, it's better to have an uh, sort of an integrated approach so that one does not unnecessarily tolerate the disease in the hope that very soon now it will be reversed and therefore I need not do anything else. And of course, we have traditional knowledge in Ayurveda, which uh, might not have been tested by the modern scientific methods, but that doesn't matter. It has another type of testing which has been done uh, through the consciousness of the rishi who initially came up with that knowledge, and through long period of several centuries through which it has worked. So that approach has a validity. I'm not denying that, but all the same, uh, there may be a situation in which, for getting quick results and for buying time, uh, medication with either insulin or oral hypoglycemics may be necessary, at least for some time. Yeah. Any other questions?
Uh, thank you, sir, for a thank you, sir, for a very brilliant and very informative lecture as usual. Uh, you have informed us about the five tests, but sometimes the doctors also tell us about the fasting insulin to get some idea about the fasting insulin. What is the role of fasting insulin in deciding about the diabetes?
Well, I mean, glucose and insulin tend to go together. So if fasting level of glucose is low, fasting level of insulin is also extremely low. And then if one can do both, that is as a result of eating, how fast the blood glucose goes up and how fast the insulin goes up, that can give a better idea. But certainly, I mean, that will be a much more sophisticated test, and will require more facilities as well, will become more expensive. Uh, for research purposes, it has been done for a very long time, but I'm not sure if in routine clinical care, it's absolutely necessary to do both insulin and glucose levels.
Okay, sir. Thank you, sir.
Another question. The gestational diabetes that happens during pregnancy, does it have to be checked afterwards also?
Yes, gestational diabetes can be taken as a warning. Women who develop gestational diabetes, usually when the diabetes disappears after the delivery of the baby. It's because of the high hormonal levels during pregnancy that the person develops diabetes. But then it's a warning sign because 50% of women who get gestational diabetes eventually develop diabetes sometime later in life. Which means that since there are 50% probability, this woman, even if she is still pretty young, in her 30s, she should try and get an annual screening done for the fasting postprandial and, if possible, oral glucose tolerance test.
That's all for the questions in the chat box. So maybe we can close today's session now with a moment of silence. So thank you, everyone.